older adults. So the topic of the lunchtime presentation today is actually what does it take? What does it really take to actually vaccinate our older Malaysians? Right. So what I'll do is actually introduce you to adult vaccination. So I know some of you probably have a little post-lunch dip, but maybe I can wake you up a bit. And if you would like to just maybe let me know which one of you have actually heard of adult vaccination. Yeah. Who hasn't heard of adult vaccination? So you can just post a yes or a no in the answer bit. Yeah. Yes, no, nobody wants to say anything. No, okay, that's good. Some people have said no. Yeah. Is one, okay? Is there one? Yeah, I suppose that's what you mean. Okay. So that's good. So maybe it's education, because we always thought of vaccination as what you go through, because when as a rite of passage as a child, where you go and get traumatized by the doctor, so you never want to see a doctor again, and then your parents always use that as a way of scaring you, or the society uses that as a way of scaring you. Don't be naughty, yeah. If you're naughty, I take you to doctor, give you injection. Yeah. So you don't quite understand what the injection is for. You just see it as a form of torture and punishment. So maybe that's why adults don't want vaccination, because they can only imagine that kind of previous traumatic experience. But why is it really not happening? We'll actually talk about in a little bit. And types of vaccination available, who should be vaccinated, and when and how to give it, and then also to talk a bit about published guidelines. Okay, so what is adult vaccination? It's anything that's given to individuals who are adults, so anyone over the age of 18. It might mean incomplete childhood vaccination. So when you reach the kind of consenting age of 18, if your parents refuse to give you MMR because of the fear of autism, then you then go back and have your MMR, then that's completing your childhood vaccination, and that's actually still considered adult vaccination. Okay, it's a continuation of adult vaccination. Sorry, someone's being a bit noisy. Do you mind turning off your mic? Okay, that's gone off now. Okay, so so with regards to, oops, come back again. That's not my dog. Okay, I'll just mute you, Dr. Tan. Okay, that's it. Yep. So right. So we can be actually talking about continuation of childhood vaccination. So do you guys know that you're supposed to actually have your tetanus vaccinations every 10 years, and every time you're bitten by a dog or prick yourself with a rose, you have supposed to have a booster? Did you know that? No, most people wouldn't have thought about it, because they think that it's over now. I'm a grown up. I don't need any more jabs. Okay. The other thing is vulnerable groups, and most of us who work in the healthcare sector are vulnerable groups. So we are exposed to infectious diseases like viruses such as COVID-19, but more usually it's influenza virus, RSV virus, or the more harmless forms of coronavirus such as coughs and colds. We are exposed to that a lot. So we actually do need to be vaccinated against some of these conditions. And I'm sure the Ministry of Health, those working in the Ministry of Health, have actually seen a drive to actually vaccinate some healthcare workers against influenza in some sectors, but not all. So it's because healthcare workers are vulnerable groups. It's hard for us to imagine ourselves as vulnerable, but we are. And then people who have chronic diseases, such as asthma, COPD, or heart disease or diabetes, they are more prone to actually succumb if they actually have viral illnesses. So they actually should also have vaccination. And those of you who are Muslims will have to go on the Hajj at least once in your life. And when you go to, if those of you who have had relatives or friends go, or if you've gone to yourself, would have remembered having to actually go through this travel clinic, and they will actually make you have a few vaccinations, particularly meningococcal vaccination. People who actually travel to Africa will be told to have yellow fever vaccination, typhoid vaccination. Those are actually quite necessary. And then we have vaccinations for older 65, which is what I want to talk about because I'm a geriatrician. Okay, so why do we need to vaccinate? Right. Vaccinations are very old. You know, it's not something that has only happened this century or last century. It's been around since 1795, and I'm sure in your history books, or if people still learn history nowadays, you remember a guy called Edward Jenner, and Edward Jenner basically inoculated a boy with cowpox because he found that the milkmaids in his village didn't get smallpox. Why? Because they got cowpox from the cows. So he actually took some cowpox from the cow, some cowpox kind of vesicular fluid, because you remember pox, smallpox, cowpox, chickenpox all have these blisters. So he took some fluid from the blister of the cowpox from a cow and inoculated it onto the arm of a boy. And then he exposed that boy to smallpox. And he became famous. He didn't go to jail because the boy didn't die. Could you imagine if the boy did die? It would have been travesty. But anyway, he was lucky. The boy didn't die, and therefore he invented vaccination. So we don't try vaccines in that way anymore, which is why even though somebody has made coronavirus vaccine all over the world, there are actually lots and over 50 types of vaccines for COVID-19 on trial at the moment, but we are not getting it because they are only just started the human trials. And in fact, the NHS Imperial College has just started a very large human trial on coronavirus vaccine. Yep, my sister tested for that, and then she found that she actually had COVID-19 antibodies, so she's not eligible for the trial. But I guess she's also not going to get COVID-19, or she's had it already. Okay, but what we are thinking about nowadays in modern days is not just prevention of the viral illnesses, because nowadays viral illnesses by and large are not so lethal. So even when we think about COVID-19, most of us, if we got COVID-19, we will not die. Yeah, but what happens when we have viral illnesses is the doctor might give us antibiotics, even though we only have a viral illness. I'm sorry if I actually are insulting any GPs out there, but it's really hard to tell, isn't it? And the patient wants antibiotics, so you just give antibiotics. But sometimes you get a secondary bacterial infection and you need antibiotics, so you then must have antibiotics. So that will actually lead to an increased use of antibiotics that is sometimes avoidable, sometimes unnecessary, but at other times necessary. But whatever the case, because we're using antibiotics a lot, to treat common colds or complications of common colds, then we are actually adding to the superbug burden of the world. Okay, by that we mean the MRSA, the Pseudomonas, and if anyone has walked into a geriatric ward recently, COVID-19 actually pulled down our superbug rates. At some point, about half to a third of our patients on the geriatric ward had actually multi-resistant organisms. So these are organisms that we cannot treat with normal antibiotics. So they all stay in for weeks now because they all need intravenous antibiotics using our last magic bullet. After that, no more. So we're actually leaving patients to die because there's no treatment when they get the ultimate superbugs. That is pretty scary. So the other thing we have is an aging population. So that's why I'm here and that's why you're here today. So this is actually quite old statistics now. I've not updated it, but as Malaya actually, Rosmalia actually mentioned, our population is aging. And by 2030, we are actually going to have nearly 5 million people over the age of 60. And that would be a trebling from the year 2000, when we only had 1.4 million people over the age of 60. Yeah, so that's more than trebled. Okay, so our population here is still very young in 2014, and that's going to increase exponentially. But we're not even there yet. We're only in 2020. And this is when Amin says, "That's not fair, Prof. Klang doesn't look like this anymore." But to be honest, our hospitals are getting too full. And it's a really big problem. So when we had to shut down so early because of COVID-19, it's because our health system could not cope. It was already stretched to the brink at normal times. So if we didn't shut down so early, lock down so early, our our healthcare system would collapse. And so our hospitals are getting very full because there are more and more older people actually living in our country. And these older people are the ones that are most susceptible when it comes to COVID-19. They are also the ones that are most susceptible when it comes to viral illnesses such as influenza that are actually preventable. But there's also bacterial illnesses that we can vaccinate against, and that is actually pneumococcal pneumonia. So we can actually do something about our overfull hospitals if we actually vaccinate. So so this is actually a study done by Dr. Amin. He is now a lecturer in emergency department at a UITM hospital, but he actually did his master's research in 1 week. So he didn't sleep for 1 week, and he stayed up in the ED department just counting how many old people come in. And he took some details from them. And in that week in 2014, well, he did it in 2013 actually, he found that in the emergency department, basically 74% of the emergency department attendances in that week, that typical week in 2013, were actually less than the age of 60. So 26% were more than the age of 60. And that's what we call, this is disproportionate. So when we look at the population at that time living in the catchment area of the University of Malaya emergency department, only 6% of those were who actually of our catchment population was over the age of 60. So there's a disproportionate representation. You might just say, oh, actually, but old people are more likely to fall sick. Why don't they should just go to the emergency department, right? So, but actually, in developed nations, the ratio of people of the population, older population attending the emergency department over the ratio of the older population in the general population is actually 1. Ours is 26-1. So there's something really, really wrong with our healthcare system. When we look at who then gets admitted, if you're young, if you're less than the age of 60, the chance of getting admitted is only round about 1 in 3, or 1 in 4. But if you are over the age of 60, the chance of being admitted if you turn up in A&E is over 50%. So then the ones who are admitted from A&E over 60s are already represented 50% of all ED attendances who were subsequently admitted. So actually our more than half of our hospital admission today actually are over the age of 60, because that was 2013, now it's now 2020. So the number of older people coming to hospital actually only just goes up. Yeah. So, okay. Right. So why are we not vaccinating then? So we know that our population is growing old. We know that older people are more susceptible to potentially preventable conditions such as influenza, such as pneumococcal pneumonia. And we know that if we vaccinate them, then they're not going to fall sick, they're not going to come to hospital. Why are we not vaccinating? This makes very little sense. You know, if I ask my 13-year-old son, he might say, how stupid. Yeah, so but actually there is no reason why why people are not vaccinating. You cannot see a rationale. So countries, so this is actually the International Federation on Aging's report at the Adult Immunization Summit in 2015. That was 5 years ago, and we're none further forward. Countries can have vaccination plans for older adults, but there is no implementation strategy and evaluation system in place. The plan may never have any effect in the country level. A barrier to prioritizing adult vaccination is ageism. Health drives economy, and prevention is an essential component of healthy aging. So when I talk about vaccination for older adults, I'm talking about prevention of falls, prevention of admissions to hospital. So part of our falls prevention strategy, when we look at the medication rationalization, is actually to see whether the older adult is actually being vaccinated against potentially preventable illnesses. Rosalind is with us. She's actually doing a master's with us at University of Malaya, and she's looking at potentially inappropriate prescribing and in patients using our falls registry. So when you look at the potentially inappropriate prescribing using the stop-start criteria, so you also define inappropriate as medications that are omitted. So we had this fight. She says, no, I cannot include vaccinations. I was like, but 100% of them are inappropriate. She says, no lah, Prof, you can't say it's inappropriate because nobody gives vaccination anyway. So I was like, then 100% of our patients have inappropriate prescribing because they are not having vaccinations. So vaccination is very, very important, and we really need to think about it. So what am I talking about? What vaccines am I talking about? This is actually the 2014 Malaysian Society of Infectious Diseases, abbreviated to MSID guidelines. So Malaysia has adult vaccination guidelines, and it is out of date because it's not been revised for 6 years. It's not easy to find these guidelines because it's not Ministry of Health guidelines. So it's actually hidden in the Prince Court Hospital website somewhere. If you look at an MSID website, you cannot find it. But what did the Malaysian Society of Infectious Diseases say about adult vaccination in 2014? So I'm only interested in old people. Yeah, I'm very biased. So when you look at over 60s, they're recommending that they have a vaccine against herpes zoster. They're recommending that they have vaccination against influenza. Then, of course, it's the unfinished childhood set, the tetanus, diphtheria, whooping cough, and then there is the pneumococcal vaccine. And they actually recommend that at the age of 65, you actually have either have a polysaccharide vaccine or a conjugate vaccine. Okay, so this is what we would like to talk about today: the pneumococcal vaccination, and I'll actually explain the difference between conjugate and polysaccharide vaccine in a bit. Okay, so let's go back to pneumonia again. Okay, so pneumonia. A lot of people think, oh, man's best friend. So why should we take it away? Yeah. So actually, the biggest cause of death in older adults is pneumonia. Okay. So community acquired pneumonia is actually an acute infection, and it actually is acquired outside healthcare settings. People don't die of community-acquired pneumonia. They're not allowed to die of community-acquired pneumonia now because most of the community-acquired pneumonia so far is actually susceptible to antibiotic treatment. So people don't die of community-acquired pneumonia. So what happens is they get the antibiotic, they come into hospital, they get the treatment for community-acquired pneumonia, and then they develop nosocomial pneumonia. So most older people now die of hospital-acquired pneumonia, which is HAP, which is actually defined as pneumonia that occurs after 48 hours of being admitted to hospital. There's also a ventilator-associated pneumonia, which occurs 48 hours after endotracheal intubation. So we're interested in preventing hospital admission and also antibiotic use when it comes to preventing community-acquired pneumonia. Okay, so this is actually a world map showing the incidence of community-acquired pneumonia in older adults. So incidence is the number of new cases per year. And older adults, usually they mean over 65, so it's over 65 here. And you can see that out of 100,000 persons, in Japan, the incidence is about 1 to 4%. Vietnam is low, either because they don't record pneumonia or because people in Vietnam are super healthy. But by and large, when you look at developed countries like Japan, Eastern Europe, United States of America, Argentina, you are actually looking at a incidence of round about 1 to 4% of the population, older population per year. So it's high. You're talking about percentages here. Okay, and this is Malaysia. This is actually Department of Statistics data in 2018. We report causes of death 2 years late. Takes 2 years to actually sort out causes of death for Malaysia. So this was 2018 data. So we won't know about the actual excess COVID-19 mortality until 2022. But this is 2018 mortality data. And as you can see, the primary cause of death in 2016, 2017 in older people aged 60 years and over is pneumonia. Okay, so pneumonia is a main cause of death for older people. In a whole population as a whole, ischemic heart disease wins, but pneumonia is number 2. Okay, so Streptococcus pneumonia, which is what we're hoping to vaccinate against, is actually the most common cause of pneumonia. Now, at this, some of you will protest because I'm sure we all do blood cultures and we all do sputum cultures and we never catch pneumococcal pneumonia. Okay, so this is it. You say, okay, it only happens in Europe. In Malaysia, we don't have pneumococcal pneumonia, and that might be one of the reasons why we're currently not giving pneumococcal injection. So I'm going to come a bit closer to home. I cannot quite get home because nobody did this study in Malaysia. Yeah, so this is actually done by a QA in Singapore, not our QA. And this actually looked at the causes distribution of microbial pathogens, so viruses as well as bacteria in Singapore. It's not a very big study, but because it's a cohort study, the quality is very good. So we can actually be quite confident about the actual integrity of the data. So when you look, what I want you to see is influenza. Okay, influenza A and B, you add together, it's 29 of 117. So it's actually near 28% of causes of pneumonia, severe community-acquired pneumonia in this cohort of patients in Singapore. So severe pneumonia pneumonia that needs hospital admission. Okay. And then I want you to draw you to this new Streptococcus pneumoniae, or the pneumococcus bug, 16%. Now I want to add 2 together. 28 plus 16% is actually nearly 50%. So if we can vaccinate our older adults against influenza and pneumococcus, we are actually looking at 50% of all causes of pneumonia potentially being preventable. This is again trying to persuade you that pneumococcal pneumonia actually affects older people most. Okay, so we already vaccinate children. Now this is the biggest crime. Malaysia started vaccinating children against pneumococcal pneumonia last year. That was actually in last year's budget. But this year's budget, so we just started this year. Yeah, I don't think they really started yet because COVID-19 kind of caused a bit of problems. But we decided we were going to vaccinate children. But pneumococcal pneumonia actually affects older adults. We didn't decide to actually vaccinate older adults. Okay, so IPD is actually invasive pneumococcal disease. So that's when you can actually culture pneumococcus from the blood, from blood cultures. So that's what we call invasive pneumococcal disease. Right. Okay, someone's trying to join. Okay, so this is actually study in Malaysia, Indonesia, and Philippines. Okay, so this is the closest I can get to home, but these are poor quality data. And we're now no longer looking at pneumococcus because the number of times we get positive cultures in our pneumonia is abysmal. Yeah, when we look at a pneumonia in total, Malaysia is actually seeing that pneumonia is affecting older adults, not babies, older adults. But we vaccinate this lot, we don't vaccinate this lot. Yeah. So why is it that older adults are actually more likely to develop pneumococcal disease and also succumb to pneumococcal disease? It's because as you grow old, your immune system ages. And also you're more likely to be immunocompromised because of all these potential illnesses that are associated with aging, and also you're more likely to have chronic medical conditions, including heart disease, chronic lung disease, diabetes, liver disease, you name it. Okay, a lot of our older adults do smoke, and it also adds to the risk factors. Okay. So let's move on and talk about things that we can actually vaccinate against. I'll quickly talk about influenza because I want to make it clear that when we talk about vaccination, we can't just say pneumococcal vaccination, influenza vaccination, zoster vaccination. We have to look at it all together. Yeah. So this is what we're worried about today: coronavirus and the flu, a looming double threat. So this winter is going to tell.
So when we looked at COVID-19 deaths by actually asking but when our social and preventive medicine department looked at COVID-19 deaths by actually begging the Department of Social Statistics to actually give us the death statistics early, we found that last year, not this year, last year, before we knew about COVID-19, between October and December, there was an excess mortality of 1,400 older adults aged 60 and over. Yeah, and that was because last December, we had an influenza epidemic. If we repeated this epidemic this year, with the threat of COVID-19, we are in big trouble. And this is Singapore data, so very near home. Yeah, people often think that Malaysia is part of Singapore, and so we shouldn't be that different. Genetically, we actually share more or less the same genes, and you can see that influenza-associated hospitalization is a problem of older adults. So in both these charts, where we actually look at the top one would be actually influenza. What do you call that? Admissions, okay, over the age of 75, and then this one is 75, okay, and actually I don't know what's the difference between both charts. They actually show the same thing. I can't remember now. Okay, B. Okay, this is 2004 to 2008, and this is 2010 to 2012. Okay, and you can see that in those 2 years, this is supposed to show that this is actually more, and the difference between all ages and the older people is actually getting bigger. But I can't trust that I can see any difference. They're about the same. Okay, right. So this is Malaysian data. So this is proof that Malaysians are not from outer space. If you give older Malaysians influenza vaccination, it works. So I don't know how anybody in 2007 could actually justify ethically to actually conduct a study like this, but this was a placebo-controlled trial where they vaccinated half of the old folks living in an old folks home with influenza vaccination and didn't vaccinate the other half. And as you can see, the vaccinated ones, they might have one influenza-like illness within the first 2 months. Well, this is the 6 months, first 2 months, second 2 months, and third 2 months. But it is much less than the number of influenza-like illnesses in the unvaccinated group. So this shows that influenza works even in Malaysians. Vaccination works even in Malaysians. And this is very, very recent data. This is work done by Pui Li, who's actually our own infectious diseases expert. We call her a geriatric infectious diseases expert because she's quite sympathetic to older people. And this shows that if you're old and you catch influenza, so these are actually people with positive swabs for flu in primary care. Then we followed them over a year and see who were more likely to die after presenting to having had a positive influenza swab in primary care. And to our greatest surprise, the percentage mortality was very high. Yeah, so actually we looked at the total number of people who actually died. All the deaths occurred in over 65, and the deaths accounted for 5%. We had 5 deaths and we had 50, so 10% of all the people. So if you present to A&E with one positive swab of influenza, you have a 10% chance of being dead at the end of that year. We don't know what they die of. I would suspect it's not going to be flu. They probably died of heart disease, stroke. But having that flu illness seemed to actually predispose them to death that year. And the number admitted to hospital is actually more than 25%. More than 1 in 4 got admitted to hospital within that year after one index presentation to primary care with influenza. Okay. So this is CDC data now, okay? So this is looking at hospital aversion. So they did some clever modeling and they decided that if you actually vaccinated an older adult against influenza, you only reduced the number of cases by 30%. But what you really reduced was actually hospitalization. So there was actually a really large reduction in hospitalization in the over 54s, 87%. 64s, over 64s. Yeah. So these are old people. Yeah. These are old people vaccinated against influenza. They don't come into hospital after that. Very effective, very powerful data. How about pneumococcal infection? So this is actually a chart showing hospital admissions for community-acquired pneumonia, not pneumococcal. As you can see, most hospital-acquired pneumonia admissions are over the age of 85. I think anyone who's been on a geriatric ward would testify for that they're all very old. Yeah. But when you look at even at this age of 65 and above, you already have an increased risk of actually being hospitalized for community-acquired pneumonia. But this is really interesting. So this is actually, I'm sorry for the small numbers, but this is actually US data showing that pneumonia is actually going down in America. Yeah, and this is actually attributed to vaccination against influenza as well as pneumococcus. Okay, and this is actually data showing that these are people with who actually die because of pneumonia. So this is we call it a Kaplan-Meier chart. So the number of this is actually the number of people still alive. So the number of people still alive after being admitted to hospital with pneumonia is actually much worse if for the unvaccinated group compared to the vaccinated group, and this is actually overall mortality, the middle line. Okay, so there are two vaccines I alluded to earlier. Okay, so this is so there's a polysaccharide vaccine. It's a much older vaccine, and it actually protects you against 23 pneumococcal serotypes. So pneumococcal is not one bug. It's actually got lots and lots of serotypes. It's just like COVID-19. Yeah, apparently they're doing so badly in US and America is because they have a more virulent serotype compared to the COVID, the one that we actually have. But pneumococcal also has lots of serotypes, and the PPV, the polysaccharide vaccine, protects you against 23 serotypes. And the conjugate vaccine, which is a newer vaccine, and it was invented for children because children cannot form antibodies with the polysaccharide vaccine. They need the conjugate vaccine, and basically only protects you against 13 serotypes. So there's actually a 10 serotype difference. I don't think I need to do the maths for you. Okay, but so what's the advantage of conjugate vaccine against pneumococcal vaccine? Right. So the thing is that this is a CAPITA study. Okay, so when we actually look at pneumococcal conjugate vaccine, okay, what it does is it very effectively reduces the risk of actually getting pneumococcal community-acquired pneumonia, and this the effectiveness is actually 75% effective. Okay, reduction. Okay, so the difference between polysaccharide vaccine and conjugate vaccine is this. Yeah, so so polysaccharide vaccine basically present the polysaccharide antigens to our immune system. Okay, so then so it actually stimulate our B cells. B cells are the cells in our body, memory cells that actually create antibodies. So then once it creates the antibodies, our body will recognize, oh, this one bad bug bite, we need to eat it up. So that's all it does. Very simple. Conjugate vaccine is far more complicated, and it's because it has a protein carrier. That's why it's called a conjugate vaccine. Now, children will not react to polysaccharide vaccine. They will not form the antibodies because their immune system is immature. So, but older adults can. But when we present the the polysaccharide attached to a carrier, a protein carrier, then we stimulate the T cell dependent immune response as well as the B cell immune response. Okay, so so we actually have double whammy. So you actually have better protection against pneumococcal vaccine. Yeah. So this explains it a bit better. So it's a protein in a conjugate vaccine. The polysaccharide is actually antigen is actually attached to a protein carrier, and then it will stimulate T cell as well as B cell response, and therefore you get extra T cell protection in addition to the B cell protection. Okay, so so this again shows that the PCV13 is actually effective above placebo. Okay, and then this one is actually showing that with regards to polysaccharide vaccine. Last time, this is an older study. They only had 7 valent conjugate vaccine then. Okay, so when you actually look at B cell response post PPV, you actually have a reduction in vaccine responsiveness with regards to older adults. This is what so what they're arguing is that when you actually give them conjugate vaccine, the older adult actually gets a far better response. So that's why a PCV, the conjugate vaccine, might be more advantageous in older adults. Okay, so but this has happened in the United States just to throw things into muddy the water a bit. So in 2000, they started introducing PCV7 in children, and then the PCV13 was introduced in children in 2010, 10 years later. So that was 10 years ago. And what we started seeing was that this is actually older adults. Okay, sorry, this is or older adults over the age of 65, all IPDs. This one is PCV13 serotypes, and this is non-PCV13 serotypes. Okay, so what you're seeing is that the pneumonia from the PCV13 serotypes have gone right down even before they started introducing the PCV7 vaccination in children. So what we're supposing is that grandchildren will actually catch the pneumococcal serotype from their friends in school. They bring back and pass to their grandparents. And so therefore we vaccinate the kids, and they're less likely to get those serotypes. But what we're seeing is an increase in non-PCV13 serotypes. So we're arguing that actually if you vaccinate children against PCV13, then you might not need to vaccinate grandparents anymore, because it actually brings a PCV13 serotype right down. The problem with Malaysia is currently children are not being vaccinated against pneumococcal, and so this does not currently apply to children. Okay, so shingles. Shingles, you all know what shingles is, right? In Chinese, they call it sangse. In Malay, they call kayak. So in Chinese, believe that it's like a snake that goes around your body. Yeah, and then when it meets in the middle, you die. But actually, no, it never meets in the middle because it only affects one side. Yeah, so this is actually the SPS study looking at a vaccine called Zostavax. So there's actually a really effective vaccine against herpes zoster. It's become available in Malaysia for 10 years now, but the uptake is very poor. The main problem is that it's actually a porcine vaccine. We have got a fatwa from the Islamic Council to say that it's okay because there's currently no alternative, but it's not really being taken up, unfortunately, because of this problem in Malaysia. But in America, it's sold like hotcakes. So actually, this vaccine actually became available 15 years ago, and it didn't leave America until 10 years ago because it was so effective. Yeah. So this overall just shows that this is the blue is unvaccinated, brown is vaccinated. Overall, in what do you call that? Terms of getting hepatic neuralgia, which is the pain you have after you get shingles, or even just getting shingles. If you take the Zostavax vaccine, then the risk of getting shingles and getting post-hepatic neuralgia is much reduced. Okay, so Zoe 50, Zoe 70, Zoe 50 refers to a study of over 50s, and then Zoe 70 is a study of over 70s. Okay, so these two studies looked at actual pneumococcal vaccine, and it actually shows that people with a pneumococcal vaccine are far less likely to have herpes zoster than those without. Okay, so we're nearly done. Okay, so this is immunization schedules. Right, so I mentioned that the MSID had already released the adult immunization schedule, the second edition of it in 2014. The first edition was, I believe, 10 years before that in 2004. So I guess we have to wait for another 4 years before the third edition. So as I mentioned earlier, older adults, you need to continue the childhood set, and then you're looking at also specific important vaccinations for older adults in terms of influenza, zoster, as well as the pneumococcal vaccine, and there are two options, the PCV or the PPV. Okay, so this is the ACIP. ACIP is actually the CDC schedule. So everybody actually doesn't look very much at the Malaysian schedule because it gets updated every 10 years, you know. So we only, most people everywhere in the world looks at CDC, do what they're doing, and then if you do what the Americans are doing, you'll not get it wrong. Yeah, right. Okay, so anyway, so influenza, okay, so the ACIP recommendation is that everybody actually has a dose of influenza through no matter how old you are. Okay, so when it comes to zoster vaccine, okay, so this is actually the zoster life vaccine. This is actually a new vaccine called Shingles. We don't get it in Malaysia, so we only have the zoster vaccine. Shingles is 90% effective. So Zostavax is only 75% effective. So, but it's only one dose compared to two doses. But they recommend over 65, you have the herpes zoster vaccine. And then PCV, they actually recommend that you actually have it at the age of 65 and over. So what's happening here? So they're recommending that you have the PCV as well as the polysaccharide vaccine. Here, I'll explain a little bit more. Okay, so basically, the PCV, as I shown earlier, it actually also brings in, it recruits your T cell immune response. So if you just give PPSV, you only have the B cell immune response. And then in older people, and those who are immunocompromised, you might have an issue with vaccine hypo-responsiveness to PPSV. So, so if you give people with PCV, you actually will get a better immune response against the 13 serotypes that are included in the PCV. But unfortunately, there's a 10 serotype difference. PPSV is 23. So the best protection is actually to take the PCV 13 at the age of 65, and then 1 year later go back and have the PPSV. But the problem is you get 2 injections and you have to pay for 2 vaccines. Okay, so so what they're recommending here is shared clinical decision making. So we actually have to talk to our patients and say, if you're poor, PPSV cheaper, you have 1 vaccine, you take PPSV. Okay, if you're rich, you take PCV, but if you don't want to be jabbed twice, you just take PCV. And if you're rich and you don't mind, you want maximum protection, you take PCV at 65, and then 1 year later you come back, you have PPSV as well. So that will actually confer maximum protection against against pneumococcal infection. Okay. So in short, vaccination in it is actually an answer to healthy aging. It's an answer to falls prevention, and not actually giving vaccination is actually ageism. It is also inappropriate prescribing, because vaccinations should, all adults should have vaccinations. Flu every year, shingles after the age of 60, and also pneumococcal infection injection vaccine, preferably PCV at 65, followed by PPSV 23 a year later. Okay, so thank you very much. So we're going to have a 15-minute question and answer session now. Okay, so I'm going to unshare. Okay, and you're welcome to okay. You're welcome to pass any comments. Okay, so yeah. So Muhammad says, oh, do I need to have tetanus? Yeah, okay. Is there okay, Adrian, do you want to unmute yourself and ask your question? Are you around, Adrian? Adrian, yep. Fire away. Oops, I can't hear you, Adrian. Okay, I'll read out your question. Is there a point of age where the possible harm stroke risk of effect of vaccination renders a vaccination less important or necessary? Wow. Okay. Shingles vaccine, it does not actually, you will not seroconvert after the age of 75. When it comes to Zostavax, after the age of 80, sorry. Yeah, so after the age of 80, it's too late. You can't have shingles vaccine. With regards to flu, there is no age that is too old as far as we know. And pneumonia, we hope that you're having it at 65 and not only thinking about it when you're at 100. But the question is whether we need boosters or not. at what point. So we don't know yet. Okay. Hi, Dickie. Do you want to unmute yourself and explain and ask your question? No? Cannot. Okay, maybe a bit noisy.
Okay.
Okay.
Yeah, Prof Tan.
Hi.
My question is, for for pneumococcal vaccine,
Mm-hmm.
are there conditions, like comorbidities that you would recommend the patient to have it earlier?
Yes. So there's actually a whole list of things that they should actually have. Yeah, so there are some conditions where there's no point giving the polysaccharide vaccine. You have to give the conjugate vaccine. People who are immunocompromised, they will not actually seroconvert with the polysaccharide vaccine. So you have to use PCV13. So and then so conditions such as chronic lung disease, of course, heart disease, diabetes, those are we call the vulnerable groups. They should actually also get pneumococcal vaccine. Yeah. So those people, very complicated, you need boosters. And the guidance does change from time to time. So it's important that you keep yourself up to date, or you refer every time you see a patient you are not sure. Yeah, so but they do need boosters because the vaccine, the kind of immune response doesn't last forever.
Would you advise, say, a 20-year-old well-controlled type 1 diabetic to have pneumococcal vaccine, say the conjugate vaccine?
I think so. Yes.
Okay.
Yeah, because
Okay.
I think the diabetes does cause immune compromise. Yeah.
Okay.
So they are very vulnerable, actually, these diabetics. Yeah, especially young diabetics, type 1s. Yeah, they can just tip into DKA anytime. Very scary. Yeah, so Adrian, you say to clarify, adult vaccination that is not recommended for a person over the age of 80. So if they're over the age of 80, it's not contraindicated. It's just that you will warn them that they might not seroconvert. So it's not recommended. Yeah. And there's no other vaccine that we wouldn't base age. We wouldn't actually vaccine based on age. Anybody? Yeah. Okay. Hopefully, you guys will actually help fight for what do you call it, vaccination in older adults. Yeah. We've just formed a group called the Malaysian Influenza Working Group, and I've been asked to lead the older person campaign to actually try and fight for vaccination in our older adults. And of course, we have to shout very loud now because we need to vaccinate our older adults before this winter. We cannot cope with COVID and influenza at the same time, and pneumococcal. So if we can actually get both, it'll be better. But I suppose we start one battle first. Yeah, and influenza hopefully will be will be available for older adults before the end of the year. Yeah. So what we're trying to say with vaccinations at the moment is that ask them to tell them that it's actually the best present they can actually give to their children, to their family. Pay for a vaccination for themselves, then they won't fall sick. They're less likely to fall sick. How do you feel about that kind of messaging? Because our government is not going to pay for it, so who's going to pay for it? They have to pay for it themselves. Yeah. So in countries such as Hong Kong and Taiwan, it's paid for by philanthropy. So these basically I think in Taiwan, this rich person, or is it Hong Kong? Hong Kong, yeah. This rich person, the relative died of pneumonia. So they found out that you can actually vaccinate against pneumonia. So they decided to actually give the government money to vaccinate all over 65s for pneumonia, just like that. So that's how the pneumonia vaccination came about in Hong Kong. Yeah, but we're quite behind when it comes to vaccination. Thailand has an adult vaccination schedule. Philippines has an adult vaccination schedule. So I have no idea why Malaysia is so blinking ageist. Even when it comes to mass gatherings, they say if you're over 60, you cannot come in. Yeah, so it's just entirely based on age. Yeah. Okay, Adrian, to persuading an older adult to actually consent against vaccination. This is very interesting. So the problem with us geriatricians and those people dealing with older adults is we think that it's necessary to get consent, isn't it? So because we always think, we always, so we talk to them about hours and hours about paying that 100 ringgit for the pneumonia jab or the influenza jab, but so we think that we have to persuade them. When I asked Prof Pang, a respiratory physician, how he actually got his COPD and asthmatics to have their pneumonia and their flu vaccine, he says he doesn't even ask. Yeah, they're going to have it. Otherwise, they can't come back and see him. So I don't know about that. Yeah, because sometimes we just feel that, there should be consent. But at the end of the day, when they fall sick, they're going to pass it. If they catch it, they're going to pass it on. If they fall sick, they're going to use our resources to treat them. So actually, there's also a public health concern, and it's a responsibility of them to actually have it on. So his vaccine uptake rate is very high because they will actually not entertain no for an answer. And apparently the patient pays for it. So I don't know. Yeah. So we are not doing something. We're doing something wrong. Yeah.